Welcome back to Advanced Human Gross Anatomy. Today we will be talking about the face. Now this may be a difficult dissection for some of you. To this point in the class we've kept the faces covered, and now we're going to start to dissect them and find their structures. You may need to do some self-talk prior to this one, but once you get busy looking for structures, I'm confident that somehow you'll likely forget the humanity of what you're working on, and you've experienced this already in labs to this point. And you will, it'll probably just feel like another day in the lab once we get into it. But the first part here, it will be a little bit tricky, just kind of to get your head around what we're doing here. So what I'd like to do is start with the last slide in this deck. This is a picture that Netter has shown here. He's drawn this. You can see these kind of lines. These lines he's drawn on the bottom here in this man's face. He's drawn this and how to make incisions in the face in such a way to prevent scarring by following these natural cleavage lines. As you're wanting to get rid of some of these other structures, here's a way that you can he's instructing how to cut through here. But we're going to use, I just want to show this top picture as kind of a model of how we're going to proceed with today's dissection. I want you to imagine an imaginary line going from the front of one ear straight up and then around to the front of the other ear. Okay, so on the top, kind of on the top of the forehead, top of the head, coming up and around like this. That's about as far back as we're going to go on the head, okay, as we dissect here. So what I'd like you to do is at the top of that incision, or at the top of that imaginary line, that kind of a coronal plane line, make an incision straight down to about the eyeballs. Okay. Now from here, what I'd like you to do is continue to cut around the eyeball, kind of around the eyelids here. So we're going to preserve the skin around the eyelids. Then from the top of that sagittal incision that you made, cut laterally down towards the front of the ear on each side. Okay, now what I'd like you to do, you can work in teams of two, a couple on each side of the body as you do this, but starting kind of at the top here, where those incisions meet, start to gently peel back the skin, start to kind of dissect down using a blunt probe, and start to take away the connective tissue, the adipose, the superficial structures here, trying to preserve the muscle underneath. This will be difficult. There's not a lot of adipose in this area, so this might be tough to find. It certainly don't expect it to look like Netter's drawing here, but do your best. Try to find a way to kind of start here and peel back as you start to come around. And this another team can start working on this side, starting from the top, peeling down and laterally here. Now, once you get to the eye, like I said, you're going to continue this mid-sagittal line straight down to about the tip of the nose, just before the tip of the nose. And then you're cutting around the eyes here, so you've cut around that, and then from the tip of the nose, cutting laterally on each side around the ala of this kind of the flared portion here down to the nostrils, and then to the cheek here. So kind of finding where those 2 points will meet, and then cutting around the nostrils on each side, right here, to about the bottom of that septal cartilage. Then you can make another small sagittal incision straight down to about the top of the lip, and then cutting around the lips, okay, on each side. So we're going to preserve the skin over the eyes, the eyelids. We're going to preserve the skin over the tip of the nose and the ala of the nose here on the sides around the nostrils. And then we're going to preserve the skin around the lips. We're not going to cut through the lips here. But once you get to the bottom, right in the chin area, you can make another incision straight down, coming underneath the neck, and then that you can kind of wrap back around up towards the front of the ear at the first incisions that you made, kind of wrapping around this way. Okay, so as you cut laterally around there, then you'll be able to eventually kind of start taking off the skin on the anterior portion of the face here. I hope that made sense as we go through that. I've written that up in a dissection guide too, so hopefully you'll be able to look at that as well. But then we'll be able to dig into some of these structures and find what we're looking for. Let's start by looking at the parotid gland here. Well, let's start by looking at the facial nerve. The facial nerve is deep to the parotid gland. You can't help but find the parotid gland here in the picture. But the facial nerve is a motor nerve for facial expression. It exits deep in the stylomastoid foramen, right back here in the skull, which we learned about in the last dissection, or last lecture. It's deep to the parotid gland here, so it kind of is housed within that parotid. We're not going to dissect down to find its origin, but I do want you to find its branches here. The parotid gland is difficult because you've seen this already in different parts that you've dissected to this point, but it's difficult to differentiate between adipose tissue and glandular tissue, and that will be certainly the case in the parotid gland in the face here. So do your best to try to differentiate, is this gland, is this mass, what's happening in this area with that tissue. But the facial nerve is going to send out a branch, this posterior auricular branch. The first branch is going to go backwards, and that's going to kind of hit the occipitalis. It's going to hit some other bones behind the ear here. So that's going to be one branch. And then forward now, there's going to be 5 more branches. And the rest of this, as it comes through the parotid, kind of splits into these branches here. So I want you to try to identify some of these things. Now, the first branch going we're going to go from superior to inferior. The first branch coming superior are these temporal branches, going more toward the temple areas. There may be several here as they branch and kind of split out on the temple area. The next branch is going to be the zygomatic branch. It's going to go towards the zygomatic bone across there, across the zygomatic arch. Next branch coming down are the buccal branches. These are going to be coming in towards the cheek. Right here, down crossing that way. Next branch coming down is this marginal mandibular branch. Right here. It's going to come down across the mandible, and then coming down into the neck are these cervical branches. Okay. Sometimes mnemonics that I give you are helpful, sometimes they aren't. The one that I remember for this is 2 zebras brought my carriage. 2 zebras, 2 zebras brought my carriage. Temporal, zygomatic, buccal, marginal mandibular, and cervical. If that helps you, great. If not, that's fine too. Bell's palsy is sometimes a diagnosis seen clinically here. This is going to be paralysis of the facial nerve. And that can happen a couple of ways. It can be brought on by an infection in the parotid gland that's maybe causing compression of those branches as they go through and causing motor innervation to be disrupted to those muscles. It can also be in the skull itself. Remember, that facial nerve takes a long route through the skull before it exits the stylomastoid foramen. If there's ossification in this canal, that can also put pressure and lead to more of a permanent Bell's palsy. This usually Bell's palsy is temporary if it's coming from kind of in the face here, but if it's in that stylomastoid foramen, in that canal, that can be permanent. That's to my knowledge, there's not a way we can free that nerve from the bone in that area. So these branches are pretty small. They can be difficult to find, but do your best. I think we'll be able to find them, certainly. The parotid duct is certainly something people should find here. That goes right over this masseter muscle before it enters the it'll empty into the right up alongside the upper molars of the mouth as it pierces through the buccinator into the mouth here. So you should all be able to find a parotid duct today, but these nerves superficially, try to find those. Now, the trigeminal nerve is a big nerve in the face here. Trigeminal nerve, remember, is the 5th cranial nerve. It has 3 branches, hence the trigeminal. There's an ophthalmic division. There's a maxillary division, and then there's a mandibular division. The ophthalmic division, you'll see here, has a couple of nerves coming out of it here, but it exits the superior orbital foramen, superior orbital fissure rather, and then out the orbit, coming out the orbit and then into these areas. You can see how it's kind of pictured in green here with the distribution of the ophthalmic branch. There's also a branch coming out of the supraorbital foramen, coming right out of above the orbit here in the frontal bone, going to the forehead. that comes this way. This is providing sensation up to about the top of the cranium. Here you can see on that green again. About the top of the cranium, kind of where we started the dissection today, kind of right in front of the ear, coming up, and then we're coming forward with the dissection. Also provides sensation around the dorsum, part of the nose here. Also, that travels with the in that supratrochlear notch that comes up and around this way. We'll talk about the supratrochlear nerves a little bit later on as well. There's also a maxillary division. This is going to exit, remember the maxillary division, V2, exits the foramen rotundum within that ethmoid bone, and then comes to the face through the infraorbital foramen. Right here you can see where that's exiting, that infraorbital foramen. Just underneath the orbit. Most of the distribution of the maxillary division is actually out of sight. It's going to be in the oral cavity and in the nasal cavity. You can see a bit of it here towards the inferior orbit, but it's going to be mostly into the oral and nasal cavities. And then the mandibular division. Remember, this one exited as well through the sphenoid bone, through the skull, the foramen ovale, and travels through it turns into these buccal nerves near that facial nerve as it comes around. Those are buccal nerves. Then it will actually exit into the mental foramen as the mental nerve coming down on the bottom of the chin here as well. I think it's worth just touching on the TMJ again, the temporomandibular joint. We talked about this a little bit more. Rigor mortis has certainly set in on these cadavers, so the muscles have seized in their position, and the opening of the jaw will be very difficult. I wouldn't suggest we try to do that in lab today, but I just want you to be mindful of this lateral ligament here, this lateral temporomandibular ligament. This comes across on the outer part of the condylar process of the mandible to help stabilize the jaw from shifting side to side here. Laxity in this joint can be quite a problem. It does have an articular disc. Here you can see there's a fibrocartilage disc that sits between the condylar process of the mandible and the mandibular fossa of the temporal bone. And you'll notice, you can see these three pictures in sequence. This is where the mouth is closed. We're starting to depress the mandible a little bit, and then a little bit more depression here. Here's a little more elevation, and back to closed. So you can kind of see how that hinges. That condylar process is going to hinge within that mandibular fossa, but it's also going to glide forward. You can see how much further forward set that condylar process is here. Lockjaw can happen if that condylar process slips forward in front of that anterior elevation there of the mandibular fossa. So things can happen with that. But anyway, I just wanted you to pay attention to that as a site of common dysfunction. Temporomandibular dysfunction can happen quite easily if there's laxity in that joint for various reasons. Okay. Let's move on to just some review of the skull, just very briefly here, a couple things. Probably should have put a picture of it facing forward so you could see that maybe a little bit better. But the frontal bone, remember here, is this top portion. That's right where we cut, right kind of on that sagittal, or the coronal suture today, but anything in front of that is the frontal bone. Forms the roof of the orbits right here. The anterior portion of the kind of the superior skull there. There's the supraorbital foramen coming right above the foramen here. This is going to be where a nerve and artery exit and a vein enters. That's going to supply the to and from the frontal bone here, kind of coming up the front of the head there. There's a trochlear notch here as well, and that's also where the supratrochlear nerve and artery are exiting, and the vein is entering, coming down into that area, traveling to and from the forehead. It runs parallel to that supraorbital artery, nerve, and vein coming up to the lateral side here. The supratrochlear is going to be a little bit more medial to that. The maxilla, you can see the maxilla bone here. Right below the orbit is that little hole. You can see it right there, the infraorbital foramen. This is where the infraorbital nerve and artery are exiting, and the infraorbital vein is entering. And that's going to spread out into an area around that portion of the bones there. The temporal bone, you can see this, the pink bone here, this funny looking bone. We talked a lot about the temporal bone before. The squamous part is this flat part here. Squama is flat. There's a petrous portion at that end of the zygomatic process as it goes more into the temporal bone. We talked about that being more rock-like. You can see it from the inside and the underside, the petrous portion. The mandible, the bone-colored shape here, the bone that sits there. You've got the condylar process. We talked about the temporal mandibular joint here. There's a coronoid process right here, which is the attachment of the temporalis, which comes from those superior temporal lines coming down inside of that zygomatic arch and attaching to the condylar process, a powerful elevator of the mandible. Talked about that. And then the mental foramen, that's another thing. That's another hole right here at the bottom of the mandible where the mental nerve and artery are exiting, the mental vein is entering, coming in through there. We'll find these today. We're trying to find those structures, the things exiting supraorbital foramen, the trochlear notch, infraorbital foramen, and mental foramens here. Okay, let's talk about some muscles. This is what you've been waiting for, right? The muscles here. So, again, they're not going to look. Don't beat yourself up. They won't probably look quite as beautiful as Netter has them placed here in his drawings, but be looking for the fiber orientation. That's the clue I'll give you today. As you look at these muscles, find the fiber orientations here. My suggestion is that it's better to know where the muscle is and then look for it than it is to just find a muscle and then try to identify it. So look for the patterns, look for the grain. These fiber orientations are going to be very meaningful with what you're finding and then ultimately what they're for. What do these muscles do? Let's talk about the frontalis here first and the occipitalis in the back here. But the frontalis and the occipitalis are connected by this epicranial aponeurosa, or this the glia aponeurosis here, that connects these two. The frontalis connects actually to the fibers of the orbicularis oris. I'm sorry, no, they don't. Orbicularis oris down here. Orbicularis oculi, right above the eyes here, and that will help to raise the eyebrows. If you, this is a big muscle for facial expression. Actually, if you could watch me do all this through the video, hopefully you can do this on your own as you're listening, but I think it helps to learn the muscles if you can mimic what they do, or ask them to work as you're learning them. So the frontalis gives you this expression of surprise or excitement, or if you raise your eyebrows, you can get the crinkles up on your forehead. Unless you've recently had Botox injections, obviously then acetylcholine's not telling those muscle fibers what to do, and you have temporarily paralyzed them. But let's assume that you haven't done that. Occipitalis in the back here, along with some some posterior auricular muscles here. These originate from that. From the neutral lines, the superior neutral line, and the mastoid process, and they're actually going to come up and insert onto that glia aponeurosis up here, right? And so what had its origin on the frontalis is its insertion on the occipitalis, coming back this way. And did you ever know anybody who could wiggle their ears? I had my grandfather on my father's side could wiggle his ears really well. That was always a fun trick. I remember as a kid watching him wiggle his ears. He had good control of his occipitalis and his posterior auricular muscles. The facial nerve sends a branch, like we said back here. Remember, the first branch kind of comes back here to that. It's called the posterior auricular nerve. Before it goes and splits into the temporal, zygomatic, buccal, marginal mandibular, and cervical branches, that posterior auricular branch is going to be what actually supplies the occipitalis. Procerus is a muscle here. This is it actually has its origin from the nasal bones here, and then its insertion up onto the fibers of the frontalis muscle here, coming up this way. This is what gives that you can have the ability to pull your eyebrows down, that look of concern. Some people have a permanent, almost contraction of these procerus muscle here on the side. The corrugator supercilii, this is another one kind of coming next to that right here. The corrugator supercilii has its origin off the orbicularis oculi muscle again, and inserting onto the skin above the supraorbital margin right here. Now this helps draw the eyebrows down and in to assist that procerus with creating that look of concern or disgust or, well, whatever emotion you want to put on that. The platysma, this is an interesting muscle. The plat means flat. Maybe they just forgot to connect the lines to make an F, to make from a P to an F. But very often this is removed, as you're taking that subcutaneous skin off of the neck here. So be very careful as you do that. Try to preserve that platysma muscle as it comes down here. And if you do find some good fiber orientation pulling down from the mandible, you can certainly remove a little more skin. I know we cut down to the chin and kind of back up and around to the front of the ear again. But if you do find some fiber orientation that's interesting, you can investigate a little bit further. You can draw down just a little bit further into the neck here and remove some of that skin to find that. That'd be great. To identify this muscle, but it's not necessary. You don't need to do that. But its origin actually comes from the fascia that covers pectoralis major and deltoid. And then it comes at these angles up towards the jaw, inserts onto the mandible and the subcutaneous tissue of the lower face. And its job is going to be to kind of pull that face down and give you that grimace. Maybe you said that today when you get, oh man, we have another quiz in anatomy. You kind of pull the face down, kind of draw the face down. That's that platysma muscle. Rhizorius is a fun one. Rhizorius is a unique muscle here. Has its origin on the fascia overlying the parotid gland, and then it inserts onto the tissue of the angle of the mouth. It actually has no attachment to bone. You'll see this a lot in the face, where you'll see how these muscles kind of connect into fascia and other fibers of other muscles around in different planes. So that's interesting. But it has if these muscle attachments are premature in their development, you may develop where you're going to pull from both sides. Usually you're going to have an anchoring point and then a pulling point. So its function would be to kind of pull the mouth backwards like this, kind of like you're smiling, like pulling the sides of the mouth back. But sometimes you'll get it where it pulls from both sides, this rhizorius muscle, because it has no bony attachment. And then you'll kind of create this little pocket as it pulls, and that kind of creates a dimple right here. You know anybody with dimples when they smile? They're kind of pulling their face back. That's kind of a misdeveloped rhizorius muscle, but we've grown to love it in our culture. Good movie stars and actors have nice dimples. My grandmother always used to love people with dimples. I didn't have them. She didn't love me, but I'm just kidding. Orbicularis oculi. Let's keep going on the eyes here. The orbicularis oculi is this. It surrounds the orbit. Okay, it's a circular fiber orientation. It comes around like this, and it's used to tightly squeeze the eyes shut. You can do it with blinking, but like hard blinking, not just the palpebra, not the eyelids, but if you squeeze your eyes shut, close your eyes tight. If foreign material is coming into the eye, perhaps, or just a hard blink, that's this muscle here. It's going to give you kind of a squinting eyes too. You can change the shape of that. I got to switch slides here to talk about the masseter. Is this muscle here? It has its origin off the zygomatic arch and inserts down on the angle of the mandible here that you can see. This is used to clench the jaw. It's going to be another powerful mandible elevator here. So it's going to come up. Clenches the jaw. The parotid duct here, you can see, is going to go, imagine the parotid gland right here. It's going to go right over that masseter. Coming this way. That's a good landmark. If you found the parotid duct, right underneath that will be the masseter. It enters into the oral cavity. You can see it pierces this muscle, the buccinator, which we'll talk about next, but it pierces that and enters just at the upper molars here, right up in the upper mouth. So if you've been to the dentist, the hygienist has maybe spent some time, maybe more time than normal, on the upper molar area. This is because there's a constant supply of saliva coming in through that parotid duct. That's a good medium for plaque buildup. So oftentimes people have extra plaque buildup right where that parotid duct enters there. So everyone should be able to find that parotid duct today, and everyone should brush more thoroughly in the upper molars. The buccinator. The buccinator is this muscle here. This is a unique one. And actually, it's a short, kind of stubby muscle, but it originates from the pterygomandibular raphe and also the alveolar processes of the maxilla and the mandible coming down this way. And it's going to kind of from the pterygoid process inside the mandible here. And it's going to insert and fuse into the fibers of the orbicularis oris muscle right here, these fibers here. We'll talk about that in a bit. I think the orbicularis oris is coming up. But it's used to produce kind of a suction, this negative pressure. This wasn't the first muscle you used when you were born. I would imagine that would have been the diaphragm or some leg and arm muscles kicking and squirming. But this was one of the first muscles you used for nursing. It kind of creates that ability to suck or to draw the cheeks in. Drinking through a straw kind of creates that negative pressure. That buccinator is going to be here. Also, if you let your cheeks fill really big, this can also help with forceful blowing too. Maybe was it Dizzy Gillespie? Who's that trumpet player with the big cheeks for forceful blowing? I don't think that's a good idea to do, but it can also help with that. Depressor anguli oris here is this muscle on the sides of the mouth. Originates from the anterolateral portion of the mandible right through here, and then inserts onto the corner of the mouth, onto the fibers of the corner of the mouth here toward that orbicularis oris. It turns the mouth kind of down and down and out here, kind of a frown, an unhappy expression coming this way. Just next to that, same kind of originating from the anterolateral mandible here, coming towards more inferior lateral fibers of the orbicularis oris. This way, a little bit different angle, is this depressor labii inferioris. So depressor anguli oris, depressor labii inferioris right here. Also going to help pull that mouth down and out, giving you that same kind of unhappy look. And then mentalis is more right in front here. And this is going to originate from the anteromedial mandible and then go right up into the fibers underneath the lip, the skin underneath the lip, and that's going to help pull the bottom lip down. Again, all these kind of frowning or unhappy expression muscles here. The orbicularis oris is what they all kind of fuse into. Again, a circular muscle fiber orientation around the mouth. This can display a wide range of motions here. You can have kind of you can put your lips together in kind of a pursed lips form, kind of a look of disgust. If you kind of purse them together but kind of pinch them tight, kind of a disgusted pursed lip move, or that you could pucker your lips. That gives a very different emotion, doesn't it? From disgust to something very different. All of these muscles of the face these particular around the mouth, a lot of expression, but these are used a lot with just speech and talking and articulating thought. A lot of expression comes from how these muscles coordinate together. Zygomaticus major and zygomaticus minor. Here you can see coming from the angle of that mouth again. This is going to come, the zygomaticus major is going to come more from that temporal process of the zygomatic bone. Zygomaticus minor is going to come from a little more medial on that zygomatic bone. But they're going to insert, again, toward the angle of the mouth. You can see minor is a little more medial insertion than major here. But they're going to be used for smiling, bringing the angle of the mouth up and out. You can picture these contracting, pulling that mouth up and out. Some people smile a little bit more with their risorius muscle. We saw that here, kind of pulling straight sideways. Some are going to pull more with zygomaticus major and minor, but you can make it all of them involved with a big smile. Everybody give me a big smile. Levator labii superioris. Now coming up on the top here, you can see levator labii, easy for me to say, superioris. There's a depressor labii inferioris. There's got to be a levator labii superioris. This originates from the maxilla underneath the orbit and is going to come down and insert onto the fascia and the muscle of the upper lip right here. It's going to help to lift the upper lip. Levator labii superioris alachnasi. That's a unique muscle here. This is going to come a little bit more steeper of an orientation. It's going to originate more medially on the maxilla and have a sharper angle than the levator labii superioris by itself. And this is going to come down and help give you kind of that snarl look. It's going to come way up on that medial orbit towards the nasal bones here on the maxilla. Remember Elvis? He would always sing with kind of of that snarled look. Maybe some of you can pull your lip up a little bit on one side and mimic that as well. Let's talk a little bit about vessels now, some vasculature. There's the transverse facial artery and vein here. You should be able to find these as you dissect across the zygomatic area. Here's zygomaticus major, it looks like, coming up this way. You should be able to find those. It's a branch actually off of the superficial temporal artery here, kind of branching off this way, going transversely this way. They're kind of small, they might be hard to find, but you can maybe look for that as well. The facial artery and vein. The facial artery is actually a branch off of the carotid artery. It originates off of the carotid artery here. It's going to travel underneath the angle of the mandible, and then it's going to come out from the mandible and kind of cross the jaw right here. You can see how it's crossing the jaw. This is actually a decent place to take a pulse. It has a good pulse. Maybe you can find that right more anterior to the angle, but right on that body of the jaw there. This is going to give a branch to the underside of the lip, the infralabial branch, and a branch to the upper side of the lip, the supralabial branch. As it ascends, it's going to continue then up towards the side of the nose and kind of end at the nasal bone, kind of at that medial superior orbit right here. There's a lot of veins here. You should be able to identify as you're dissecting what's vein and what's artery. Arteries are going to have a much more substantial shape to them. They're going to have that nice strong tunica media. The veins are going to be a little more wimpy, a little more flimsy. It's okay with me if as you're dissecting and crisping up some of this dissection today, if you get rid of some of the veins. But try to keep those arteries. Try to identify some of the things we're identifying here. Again, the parotid duct. You can see here coming right from that parotid gland, crossing the masseter before it pierces the buccinator here. Nice shot of that. Also in this area, what you might find, sometimes we'll be dissecting here and you'll find this, there's a fat pad. It's the buccal fat pad. It looks like a big kind of like a rubber ball of fat. It's just as you're peeling the skin off, you might actually kind of pop out or pop off there as it comes out of this area. It kind of is. There's a depression you can see here between the masseter, between zygomaticus major and the mandible itself. Is this kind of this depression, and well, you might find that as you're dissecting, which that's interesting to find a little piece of fat there. Okay, let's talk about the nose a little bit now. The nose is interesting in lots of ways here. We'll talk about it just for a little bit from the cartilage perspective. We've already cut down, remember to dissect, we've cut down to about here and then made these lateral cuts around the ala of the nose, around the nostril, and then back to midline to cut around the lips. Remember we did that as we're taking the skin off. If you ever need a rhinoplasty, a surgical, usually elective, sometimes traumatically necessary, but where you're going to change the shape of your face, a nose job. I want to get a different kind of nose here. You want to find a skilled surgeon because cartilage has no blood supply to itself. Cartilage typically gets its nutrition from the surrounding connective tissues, and it's a pretty tough surgery. You want to find a very skilled plastic surgeon there. But what you'll see here on the edges and the outsides here, what you've taken the skin off from is these lateral nasal cartilages here, or here you've seen they're called the lateral processes of the septal of the nasal cartilages here. So these lateral cartilages from the nasal bone down on each side to the nostrils, and then on the inside here you can see the septal cartilage is this middle portion. Here you can see a little part of it on the bottom, the septal cartilage, and then you've got the alar cartilages here on the outsides, and they're from the nostrils at the ends of the lateral nasal cartilages here. So lateral plates here, lateral processes. Here's the alar cartilages. Here the septal cartilages in the middle. That's what I wanted you to see there. We'll touch on the ear as well. We're not going to dissect into the ear. Our incisions were in front of the ear today, but you'll certainly be able to see this big satellite dish that we have on the sides of our head. this is the external ear, or the auricle on the outside here, all sorts of bumps and grooves in there. There's the external auditory meatus that we'll be able to find as it goes in. If we look deep inside there, here's the the eardrum, the yeah, tympanic membrane. That's what I was thinking. Tough. Sometimes I forget what I'm talking about here. But the external auditory meatus coming, the external acoustic meatus coming through there to the middle ear, which would start at the tympanic membrane there. Let's talk about the eyes now a little bit. Just a few more things to discuss here. The eyes are interesting. Now we've preserved the eyelids. Okay, we've cut around this as we've come around here. Okay, so hopefully we can see that. But the eyelids are the palpebra, or there's a superior and an inferior palpebra. The eyelids that you can see. Here's the superior and inferior palpebra. We've cut around this, like I've said. But the palpebral commissure. This is kind of at the medial and lateral angles where they meet. Right here and right here, here and here, so that where the superior is going to meet the inferior is going to meet the superior is going to meet the inferior. So you should be able to kind of notice those. The palpebral rima, or the fissure, this is where they connect in the middle. This is where the superior and inferior palpebra, the lids come together when the eyes are closed. Right there, that fissure, this palpebral fissure. The cornea of the eye is this anterior portion of the eyeball that's continuous with the sclera in the back, this outer tunic here. So sclera is the whites of the eye. The cornea is where you would put your contact lens, right up on top here. And then it continues back onto the sclera all the way around the eyeball, except obviously where the optic nerve exits in the back here. The iris is this anterior projection of the choroid plexus here, that middle tunic of the eye that comes in front, the vascular tunic that comes in front here. This is what gives the colors of the eye: brown eyes, blue eyes, green eyes. Comes this way. There's smooth muscle in here in a couple different orientations. It acts like a shutter when it closes. It will kind of act in this letting light in and out here, but there's a circular contraction of the smooth muscle as the pupil closes, and it will kind of circularly contract down. And then as in darker spaces, when the pupil needs more information to be sent in, more light to be coming into the eye, it will kind of have these radial fibers that pull out and open up the pupil. It will contract circularly down and contract radially out. The pupil is actually not a structure. It's actually the absence of a structure. It's just this place in the center of the iris which does not connect to itself here. The conjunctiva. The conjunctiva is this lining right onto the eyelid, and then it comes down onto the cornea as well. So onto the cornea and the eyelid, and it kind of loops back. It bends backwards here, coming around this way. The bulbar conjunctiva is the lining on the cornea, and the palpebra conjunctiva is the lining on the eyelids here itself. And so it kind of makes that bend as it comes back around there. This is why you can't actually lose a contact lens behind your eyeball. You can't do it. Some people's conjunctiva ends pretty high, but it's just going to be back here. If you look around deep enough, if you keep searching, you'll find it either as it slips down or around. This is obviously just a cross section, but if you were to imagine the 3D picture, you're coming around on either side too. But the conjunctiva is what keeps it in place. It can't go behind the conjunctiva. I promise. Don't ask me to get it out, but yeah, you will eventually get it out. The eyelashes, you can see, are at the ends of the palpebra here, the ends of the lids. And here's just a cross section. You can see where the eyelashes would come out. But there's little tarsal glands here. These are like sebaceous glands in your skin for hair follicles, but they're at the eyelashes, or at the eyelids here. So for lubricating those eyelashes as they come out. There's a tarsal plate right here. You can see those tarsal glands are right at the ends of the tarsal plates. Everybody in elementary school, I'm sure, knew the kid on the playground who would flip their eyelids inside out. There's just this firm plate in here where some kids would be able to kind of pull it out and then flip that tarsal plate so it was resting on the cornea. And then you could see the underside of the palpebra here. Those are the people who probably lost their contact lenses behind their eyes later in life. But that's that tarsal plate inside there. The next thing we'll talk about in the eye is this lacrimal apparatus. This is interesting here. The lacrimal apparatus. We won't actually see this today, but I won't. I think it's good to just discuss this and notice what's happening around here. We've seen some of these other structures, but don't necessarily dig around trying to find all these structures today. But the lacrimal gland is actually on the superior lateral portion of the orbit here. You can feel it just underneath the bony ridge of the orbit. It's about the size of an almond. It's actually quite big, the superolateral aspect of the orbit here. It has lacrimal ducts that will, here you can kind of see this picture as this kind of dissected away. These lacrimal ducts are going to deliver the lacrimal secretion, the tears, the lacrimal secretion down onto the upper lateral portion of the eyeball here, okay, right underneath the eyelid. And then the contractions of the orbicularis oris and, I'm sorry, boy, I get those confused, and I don't need to, and that's not helpful to you, I'm sure, but the orbicularis oculi. Orbicularis oris is around the mouth. Orbicularis oculi is around the eyeball. So contractions of the orbicularis oculi with blinking will help distribute those tears across the eye as they come down and around and down and around, coming this way. And they'll eventually they'll congregate all the way towards the middle aspect of the eye here. Now, right at the inside of the eye here, you'll find a curricula, or a caruncle. Sometimes the books will call it the curricula here. There's a superior and an inferior caruncle here. These large bumps at the medial angle of the eye. Right here. They're kind of like a diverter. They're going to bring that fluid, that lacrimal fluid, toward this lacrimal papillae, which is a smaller bump that sticks out from the eyelid right here on the inside, that lacrimal papillae. And then there's a punctum right in the inside here. This is going to be a small hole in the lacrimal papillae, all these holes, all this funneling down that helps drain the tears into these lacrimal canaliculi. You can see the canaliculi, these tiny little passageways that bring it from the eye now into the lacrimal sac. So we won't see the canaliculi today, but they're draining into the lacrimal sac, which is found within that depression of the lacrimal bone. Remember, we saw that little depression within the bone in a previous lecture. So then there's the nasolacrimal duct, which drains from the canaliculi into the nasolacrimal sac, and then down into the nasal cavity, into this inferior meatus underneath that inferior nasal concha through the nasolacrimal duct. Okay, as it comes down. So starting at the parotid gland, making its way over the eyeball, then you go through the caruncle, or around the caruncle, into the punctum, into the papillae, into the punctum, into the nasolacrimal sac, into the nasolacrimal canal, or duct rather, and then into the inferior meatus, just below the inferior nasal concha. Whew. So, when you're crying, or if you have hay fever or allergies or anything that's increasing the production of lacrimal, of the lacrimal gland, these tear productions are going to come down, and you're going to end up having to blow your nose a lot if those things happen. And for some reason, humans, I don't know why the sympathetic nervous system gets involved with emotions, but for some reason we're good at producing excess lacrimal fluid at times of emotional stress. So not only will it just lubricate and keep the eye happy, but you might actually have it spill over and you get these tears coming down the eyes this way. So that can happen as well. Okay, let's just finish up, just touching on some nerves here, just a little bit more on the nerves. I just want to make sure we're clear on that trigeminal branches here. So finishing with this, we've already touched on this, but the supraorbital nerve is going to come out here. Now, remember, whenever we talk about these nerves, there's going to be an artery and a vein as well, but we'll just see the nerves here. Supraorbital nerve is going to come out of that supraorbital foramen, and then travel up onto the forehead. The supratrochlear nerve is going to come out that supratrochlear foramen, and it's going to travel up that forehead medial to the supraorbital nerve this way. And then you've got these external nasal nerves coming out this way. These are actually going to come out from the orbit and travel onto the dorsum of the nose. Now, all of those, supraorbital, supratrochlear, and external nasal, these are divisions, these are branches off of that ophthalmic division of cranial nerve number 5, the V1 of cranial nerve number 5, the trigeminal. Okay, now the infraorbital nerve right here, along with an artery and vein, but this is going to come out of that infraorbital foramen, and this is going to be a branch of the maxillary division of trigeminal, or V2, right? Now the mental nerve down here is going to come out of that mental foramen, and that's going to be, along with those buccal nerves, this is going to be branches of V3, the mandibular branch, or the mandibular division of the trigeminal. Okay, so hopefully we can be able to find some of those today. That's important for us today. Now, just ending with our what we started here, just as a review very quickly on what we're looking for today. So this is going to be probably the most skilled dissection that you'll have to date. This is going to be the trickiest one yet. Again, there's not a lot of connective tissue here, so really try to do your best to preserve the nerves and the artery branches underneath the skin, over the muscles, but try to just take the skin and the cutaneous layers off, but try to preserve as much as you can of the structures that we've discussed today. Again, you're going to cut around from the top. You're going to cut around the eyes. All right, you're going to continue down the nose, around the ala of the nose, around the nostrils, and around the mouth as it comes down onto the chin. On each side, you're going to do this. So hopefully that was helpful. You use a blunt probe, again, to dissect away the muscle, to preserve that muscle underneath. And again, you can come down a little bit deeper onto the platysma. If you want to look for that platysma on the neck, you can do that as well. But I hope this was helpful. I look forward to seeing you in lab and seeing what we can do. Thank you for your time. Have a wonderful rest of the day.